Hello everyone and welcome to our video on valve disease. By way of brief review, there are four cardiac valves. The right-sided valves are the tricuspid valve and the pulmonic, and the left-sided valves are the aortic and mitral. And all of these valves can develop problems where they don't open or close properly, and that's what we'll talk about in this video. In other videos, I talk in detail about Wigger's diagram and heart murmurs and other things related to valve disease. In this video, we're going to focus on the hemodynamics and the causes of individual valve lesions. Cardiac valves can develop either stenosis or regurgitation. Stenosis is when there is stiffening or thickening of the valve leaflets, and this leads to an obstruction of forward blood flow across the valve. In regurgitation, there is malcoaptation of the valve leaflets, and what I mean by this is that valve leaflets are supposed to come together and seal to prevent the backward flow of blood. If they do not come together normally, that's called malcoaptation, and that leads to leakage of blood flow backwards across the valve. You can also classify valvular heart lesions in terms of the portion of the cardiac cycle in which they occur. So valve lesions that occur in systole are caused by the heart contracting or squeezing and driving blood flow across an abnormal valve. This occurs in aortic stenosis, also mitral regurgitation. It also occurs in pulmonic stenosis and tricuspid regurgitation. All of these lesions are caused by the ventricle contracting and squeezing and driving blood either forward across a stenotic valve or backwards across a leaky valve. In contrast, valve lesions that occur in diastole occur when the heart relaxes or fills. So these are lesions like aortic regurgitation or mitral stenosis or pulmonic regurgitation or tricuspid stenosis. These lesions are caused either by the left ventricle relaxing and blood being drawn in, or they are caused by the left atrium contracting and pushing blood across a stenotic valve. The treatment of valve disorders is not something likely to come up on the step 1 exam, but I'll just briefly mention here that only severe valvular lesions are treated. So many patients have mild or even moderate valvular lesions, and we generally leave these untreated. The heart can tolerate those lesions well. We only treat valve disease when it becomes severe, because at that point it can impact the left ventricle and lead to heart failure. Most valve disorders are surgical diseases. In general, the treatment for all of the conditions we'll talk about in this video is surgery. Some valves can be repaired, especially mitral valve prolapse is a classic valvular lesion that can often be repaired by the surgeon. The surgeon can cut out the prolapsed section of the valve and tighten it up, and this will eliminate the mitral regurgitation. In most cases, however, the valve has to be replaced. There are two options. One is a bioprosthetic valve. This is made out of tissue from a pig or cow attached to a polymer ring that replaces the valve. The other option is a mechanical valve. This is made out of metal, and it lasts much longer than a bioprosthetic valve, but it requires lifelong anticoagulation with a drug like warfarin. And then finally, in some stenotic valve lesions, valvuloplasty can be performed. In this procedure, a large balloon is placed across the valve and inflated, and the idea is to break up fibrous tissue and calcium and make the valve more mobile. Before we get into specific stenotic valve lesions, let me briefly review rheumatic fever, which is the cause of many valve disorders in the heart. Rheumatic fever occurs weeks after a streptococcal pharyngitis sore throat infection. It's common in children. It's an autoimmune reaction. It's an example of a type 2 hypersensitivity reaction. And the cause of rheumatic fever is that antibodies produced to bacterial M proteins found in streptococci cross-react with proteins in the heart. The Jones criteria are the criteria used for diagnosis of acute rheumatic fever, and you can use the mnemonic Jones to remember the signs and symptoms of rheumatic fever. So children with acute rheumatic fever develop joint pain. They have polyarthritis, which means arthritis involving more than 5 joints. They also develop carditis. Carditis means inflammation of any part of the heart. This could be a valvulitis. An inflammation of the cardiac valves can lead to regurgitation in acute rheumatic fever. You can also see myocarditis, which is inflammation of the myocardium, and pericarditis. These children can develop subcutaneous nodules. They also classically develop a rash on their trunk called erythema marginatum. And then finally, they develop a jerking movement disorder called sydenham-chorea. Rheumatic heart disease is long-term chronic damage to the heart valves caused by acute rheumatic fever, and you should be aware that the mitral valve is the most commonly involved valve, and we'll talk more about mitral stenosis later. That is a valve lesion classically caused by rheumatic heart disease. Rheumatic heart disease often presents years after acute rheumatic fever, and many patients with acute rheumatic fever do not have all those signs and symptoms of the Jones criteria, and in fact many do not recall any acute episode at all. Probably they had a mild febrile illness with minimal symptoms that was actually acute rheumatic fever. They only realized what it was years later when they developed chronic valvular disease from rheumatic heart disease. And you should be aware that rheumatic heart disease is much more common in developing countries compared to the United States. This is because in these parts of the globe there's limited access to medical care for pharyngitis, so many children go untreated for strep throat. As a result, they have more time to develop antibodies and more likelihood to develop rheumatic heart disease later in life. And in terms of board question strategy, this means that rheumatic heart disease will often be described in someone who is an immigrant to the United States. The other condition I want to briefly discuss before we get into specific valve lesions is carcinoid heart disease, because this is another common cause of valvular heart lesions. Carcinoid heart disease is caused by carcinoid tumors of the intestines, and I have an entire video on this in the GI section. These tumors secrete serotonin, and for reasons that are poorly understood, this leads to fibrous deposits on the tricuspid and pulmonic valves. This can lead to both stenosis and regurgitation of these valves. Now, it turns out that serotonin is inactivated by the lungs, so left-sided lesions, like lesions involving the mitral and aortic valves, are very rare in carcinoid heart disease, but tricuspid and pulmonic valve lesions are a common sequelae of this condition. We'll start by talking about stenotic valve disorders. In these disorders, the valve becomes stiff and there is a pressure gradient across the valve. And by this I mean that there is a high pressure upstream and a lower pressure downstream. To understand this, imagine that we have a couple of leaflets of the aortic valve right here. We'll call this the aortic valve. And normally what we need to do is get the pressure inside the left ventricle on this side of the valve just slightly higher than the pressure in the aorta, and the valve will open. So for example, if the aortic pressure is 120 millimeters in systole, then the pressure in the left ventricle needs to only be 120.1 millimeters of mercury, and then the valve will open, because the valve is providing very little resistance to flow, and as soon as the pressure gets just a tiny bit higher in the left ventricle and then the aorta, the valve opens. What we see in aortic stenosis is that this valve becomes very stiff and thickened and it's hard to open. In this case, the pressure inside the left ventricle has to get much higher, let's say as high as 150 millimeters, in order to open the valve. This is a gradient of 30 millimeters between the left ventricle and the aorta in systole, and that's what's seen in aortic stenosis. Okay, now we're ready to finally start talking about specific valve disorders, and let's begin with aortic stenosis. So the pathophysiology of AS is that it's a stiff aortic valve. It's a problem in systole. The valve cannot be opened. And in terms of cardiac physiology, what this does is increase the afterload on the left ventricle. Just like I told you before, normally the left ventricle only needs to increase the blood pressure inside the chamber to about 120 millimeters to open the valve. In the case of aortic stenosis, it has to generate a much higher pressure to open the aortic valve. Sometimes the pressure inside the chamber can be as high as 200 millimeters or more in systole. That's a tremendous increase in afterload on the left ventricle, and that will increase the myocardial oxygen demand. The hemodynamic hallmark of aortic stenosis is a left ventricular systolic pressure that is higher than the aortic pressure. For example, the left ventricular systolic pressure may be 160 when the normal is 120. The systolic blood pressure in the aorta may still be 120, which is normal. This gives a gradient of 40 millimeters. This is a common and classic finding in aortic stenosis. And in the video on Wigger's diagram, I talk about the Wigger's diagram for aortic stenosis. And by way of brief review, on the left side at the bottom of the screen is a normal Wigger's diagram. And you can see that the aortic and left ventricular pressure curves are right on top of each other. But in aortic stenosis, there's this large gradient in pressure difference. There's a big pressure difference between the aortic pressure, which is the red line here, and the left ventricular pressure, the green line here. And this pressure difference is caused by aortic stenosis. Now, because of the increase in afterload, the left ventricle becomes very stiff, and this means that for any given volume of blood inside the chamber, the pressure will be higher. So the other hemodynamic consequence of aortic stenosis is that the left ventricular end diastolic pressure rises due to afterload. Once again, if you look at Wigger's diagram, this is the pressure at the end of diastole shown here. This pressure will go up in patients with aortic stenosis, and that's because of the stiffening of the left ventricle. The clinical features of aortic stenosis are a systolic crescendo-decrescendo murmur, which I talk about in more detail in the video on heart murmurs. The symptoms of aortic stenosis include syncope, and this is because the cardiac output cannot rise during exercise due to increased afterload. So a classic history is a patient who is walking and then suddenly faints, and on physical exam has a systolic murmur. Angina can also occur. This is because of the rise in left ventricular end diastolic pressure. This decreases coronary blood flow. So if we have a coronary artery here, let's say for example it's the LAD, the pressure pushing blood into the LAD is the diastolic blood pressure, so let's say that's 80 millimeters of mercury. The pressure at the other end of the vessel is the left ventricular end diastolic pressure. Now normally this pressure is about 10 or so, and that gives a driving force of blood flow through the LAD of 70 millimeters, the difference between 80 and 10. But now you can imagine if this pressure rises and becomes, let's say, 25, we've now lost our driving force for blood flow through the LAD, and that's going to decrease coronary blood flow and potentially cause angina. And then finally, left heart failure can also occur because when the left ventricular end diastolic pressure rises, this is transmitted backwards and it raises the left atrial pressure, and that can lead to pulmonary edema and heart failure. The most common cause of aortic stenosis is called senile aortic stenosis. This occurs in patients usually in their 70s or 80s. It's a wear and tear lesion where the aortic valve breaks down from opening and closing over decades of a person's life. Specifically, collagen breaks down and calcium deposits and the valve becomes stiff. This is a picture of a tricuspid valve that has been removed for aortic stenosis at the bottom right side of the screen. Another common cause is a bicuspid aortic valve, as shown at the top right side of the screen. Bicuspid valves also develop wear and tear aortic stenosis, but they do so at a younger age. So patients with bicuspid aortic valves often develop aortic stenosis in their 50s or 60s compared to 70s or 80s for patients with tricuspid valves. And then rarely, rheumatic heart disease can cause aortic stenosis, although, as I mentioned before, the mitral valve is the most commonly involved valve. Usually when aortic valve disease occurs in rheumatic disease, it is together with mitral valve disease. Let me briefly mention supravalvular aortic stenosis. This is narrowing of the ascending aorta above the aortic valve that leads to the same hemodynamics as aortic stenosis. And what you always want to remember about this very rare clinical scenario for board questions is that it's seen in Williams syndrome. Williams syndrome is a genetic deletion syndrome that I talk about in more detail in the genetics section, but I just want to mention here that it often involves supravalvular AS. Moving on, let's talk about mitral stenosis. So the pathophysiology of mitral stenosis is that it is a stiff mitral valve problem. This creates a problem in diastole. That's when the mitral valve should open to allow filling of the left ventricle, but it's difficult for the valve to open when it has become stiff and thickened. This creates a gradient between the left atrium and the left ventricle in diastole. Normally the left atrial pressure is about 10 and the left ventricular end diastolic pressure is also about 10, such that there is no significant gradient between the two chambers. In mitral stenosis, the left atrial pressure can get as high as 20 or even higher, and the left ventricular end diastolic pressure actually is usually low because it's difficult for the left ventricle to fill. So this can create a gradient of 10 or 15 or 20 millimeters as seen in mitral stenosis. And from a hemodynamic standpoint, there is a decreased preload on the left ventricle. That's what you want to remember. It's hard for the left ventricle to fill with blood when there's a stiff mitral valve. Mitral stenosis is almost always a consequence of rheumatic fever. That's the major cause of this condition you want to remember. Most patients with mitral stenosis had rheumatic fever as a child and years later developed mitral stenosis. The most common symptom is dyspnea. This is because, as I told you on the last slide, the left atrial pressure gets very high and that's transmitted backwards to the lungs, and this leads to pulmonary congestion. Decades ago, when there was no treatment for mitral stenosis, this disease was famous for generating an enormous left atrium because of the high left atrial pressure. In some cases, the left atrium could get so large that it could compress the esophagus and cause dysphagia, or compress the recurrent laryngeal nerve and cause hoarseness of the voice. This is not seen in the modern era, but it can occur when the left atrium gets enormous from mitral stenosis. And the murmur, which I talk about in another video, is a diastolic murmur. It's a diastolic rumble with an opening snap. Tricuspid stenosis is a very rare valve disorder. It's almost never seen. It causes a diastolic murmur just like mitral stenosis, but the point where the murmur is loudest is the left lower sternal border. This is a different location from where mitral stenosis is heard. When tricuspid stenosis does occur, it's caused by rheumatic fever, usually together with mitral valve disease. However, tricuspid regurgitation is a much more common consequence of rheumatic fever than tricuspid stenosis. The other situation where you can sometimes see tricuspid stenosis is among patients with carcinoma heart disease. Pulmonic stenosis is also a very rare valvular lesion. It can occur as a congenital defect in a child. This is because in some children the commissures are fused. In other words, the valve doesn't perfectly split into 3 leaflets, and sometimes this can lead to thickening of the leaflets in pulmonic stenosis. You can also rarely see pulmonic stenosis as a consequence of carcinoid heart disease. Moving on, we're going to talk about regurgitant heart lesions, and you should be aware that these type of valvular lesions come in 2 flavors, the acute and chronic forms. So acute regurgitation is usually from endocarditis. A patient develops a bacterial infection of a valve and they can get severe acute regurgitation of that valve. This can sometimes cause shock and activation of the sympathetic nervous system, and because the sympathetic nervous system is activated, you can see increased contractility. You can also see vasoconstriction and increased afterload. In this video, I'm going to focus mostly on the chronic regurgitation lesions. This is what you're usually tested on. In chronic valvular regurgitation, there's no shock. However, there is a risk that over time, this will lead to chronic heart failure, and usually the sympathetic nervous system is not activated unless there's severe end-stage heart failure. We'll start with aortic regurgitation. So this is when blood leaks across the aortic valve while the left ventricle is relaxing. This is a diastolic problem. Normally, when left ventricular relaxation is occurring, the aortic valve should be closed. In this case, the aortic valve is leaking, so blood fills the left ventricle even when the chamber is relaxing. Because blood fills the chamber during relaxation and diastole, there will be an increased preload and an increased stroke volume among patients with this condition. In addition, patients with chronic aortic regurgitation have increased afterload. This is not intuitive. This is just something you have to know. The reason is because you are chronically pushing a high stroke volume into the aorta, and all this volume is banging into the aorta, and over time that stiffens the aorta and decreases the compliance of the aorta, and this will increase the afterload. This is a very peculiar fact. Hopefully they won't ask you about this factoid on your exams. And the murmur of aortic regurgitation, as I talk about in the murmur video, is a blowing diastolic murmur. Shown on this slide are causes of aortic regurgitation. Any process that leads to a dilated root of the aorta can pull the aortic valve leaflets apart, and this can lead to regurgitation. This is often seen among patients with hypertension or patients with any other cause of an aortic aneurysm. For example, patients with Marfan syndrome often have aortic aneurysms, and this can lead to aortic regurgitation. You can also develop aortic regurgitation from tertiary syphilis. This is basically unheard of in the modern era, but years ago when there were no therapies for syphilis, patients would develop tertiary syphilis, and as part of that process they would develop aortitis, and this often led to aortic regurgitation. Earlier I told you that patients with bicuspid aortic valves often develop aortic stenosis. They can also develop aortic regurgitation, and by way of review, bicuspid aortic valves are commonly seen among patients who have Turner syndrome. They're also more common among patients who have coarctation of the aorta. Anytime a valve develops endocarditis after the endocarditis resolves or during the active infection, patients can develop a leaky valve. So aortic valve endocarditis can lead to aortic regurgitation. And then rheumatic heart disease can rarely cause aortic regurgitation. This almost always occurs together with mitral valve disease. Clinical features of aortic regurgitation are shown in this slide. The blood that leaks back into the left ventricle causes a low diastolic blood pressure, and it's very high yield to understand this. If we follow blood pressure over time in a particular patient, we would see that the blood pressure rises to a pressure that is the systolic pressure, and then it falls to a pressure that is the diastolic pressure. In patients who have aortic regurgitation, the blood pressure falls much lower than normal, and that's because blood is leaking back into the left ventricle and out of the aorta and out of the arterial tree. So these patients tend to have a very low diastolic blood pressure, and this gives them a very high pulse pressure, the difference between the systolic pressure and the diastolic pressure. It gets very large in aortic regurgitation. This is a classic cause of a large or widened pulse pressure. So I've summarized these points on this slide. If 120/80 is a normal blood pressure, you may see a blood pressure of 120/40 in a patient with aortic regurgitation. They have that low diastolic pressure. They also have a wide pulse pressure. This happens because the diastolic pressure is low. It also happens because the cardiac output goes up in aortic regurgitation. Remember, the preload is increased. The ventricle is filling with more blood than usual because of the leaky aortic valve. So the high cardiac output causes the systolic blood pressure to potentially rise, and then you have a low diastolic pressure from the leaky aortic valve. So this combination leads to a wide pulse pressure. And once again, aortic regurgitation is famous for having a wide pulse pressure. And because of this wide pulse pressure, there are a number of symptoms that are unique to aortic regurgitation. Most of these aren't seen in the modern era. They're historical from older times when patients had long-standing untreated aortic regurgitation. But these patients could have water hammer pulses. These are pulses that were extremely vigorous because of the high cardiac output. Patients would sometimes have head bobbing because of the wide changes between the systolic and diastolic pressure, and there are many, many other classic findings in long-standing aortic regurgitation that are mostly historical. Now let's move on to mitral regurgitation. In this condition, blood leaks across the mitral valve and fills the left atrium. This will raise the left atrial volume, and those myocytes in the left atrium will be stretched, and then via the Starling mechanism, they will pump more blood and increase the left ventricular filling from the left atrium. So if you understand this, it's easy to appreciate that the hallmark of mitral regurgitation is increased preload and increased stroke volume. Another way to think about this is if the left ventricle needs to pump 5 liters per minute forward to the body to meet the body's oxygen requirements, and then it develops a leaky mitral valve such that 1 liter per minute is going backwards into the left atrium. The left ventricle now has to pump a total of 6 liters in order to still meet that body's need of 5 liters per minute going forward. So anytime there's mitral regurgitation, the left ventricular stroke volume has to go up so that the ventricle can continue to meet the needs of the body. Another feature of mitral regurgitation is reduced afterload, and this is in contrast to aortic regurgitation where there's more afterload. In mitral regurgitation, there are 2 places for the left ventricle to pump blood, not just to the aorta, but also backwards to the left atrium. This gives it more places to push the blood to, and the left atrium is a low pressure chamber, so overall this leads to a reduced afterload on the left ventricle in mitral regurgitation. That's the opposite of the increased afterload seen in aortic regurgitation. Mitral regurgitation is called primary mitral regurgitation when it's caused by mitral valve prolapse. This is also sometimes referred to as degenerative or myxomatous mitral regurgitation. In mitral valve prolapse, there's a stretching or billowing of the mitral valve leaflets above the annulus. This is shown in this picture at the bottom right side of the screen. The top picture is how the mitral valve should look. The bottom picture is how it looks in mitral valve prolapse. You can see that these leaflets and cords are stretched such that they billow like a parachute up into the left atrium. And mitral valve prolapse, when it occurs, commonly leads to mitral regurgitation. Over time, the leaflets will break down and blood will begin to leak backwards. Mitral valve prolapse causes a systolic click, which I talk about in more detail in the video on heart murmurs and heart sounds. And just to avoid confusion, don't mix up the systolic click of mitral valve prolapse with the opening snap of mitral stenosis. There are a couple of unusual sounds, the click and the snap, associated with mitral valve disease. The snap goes with stenosis. The click is what's seen in mitral valve prolapse. Mitral regurgitation can also be secondary to ischemia. If a patient has had a myocardial infarction, there can be damage to a papillary muscle, and this can lead to mitral regurgitation. In addition, many patients who developed a dilated cardiomyopathy have dilation of the left ventricular cavity. When this happens, the leaflets pull apart, and this leads to mitral regurgitation. This is often called functional MR because there's nothing wrong with the valve. It's just that it's not functioning properly because of the dilated cardiomyopathy. And then finally, patients with hypertrophic cardiomyopathy often develop mitral regurgitation, and I talk about this in the video on hypertrophic cardiomyopathy. Some additional causes of mitral regurgitation are shown on this slide. Endocarditis can lead to mitral regurgitation just like it can lead to regurgitation of any valve. Rheumatic heart disease sometimes causes mitral regurgitation in addition to mitral stenosis. And then there are a number of congenital heart defects which involve mitral regurgitation. So a cleft mitral valve is a mitral valve that is missing a portion of one of the leaflets. This is seen as part of endocardial cushion defects, which often occur in children with Down syndrome. And then finally, mitral regurgitation causes a holosystolic murmur heard at the cardiac apex, and I talk about this in more detail in the video on heart murmurs. Let me briefly mention afterload reduction as a treatment for aortic and mitral regurgitation. Now, like I told you before, valvular heart disease is basically a surgical problem. But in theory, if you could reduce the afterload on the left ventricle, you would improve the forward flow. Remember that in both aortic and regurgitation, the left ventricle has the option of pumping the blood forward, or the blood can leak backwards into the left ventricle in the case of aortic regurgitation, or the blood can leak backwards into the left atrium in the case of mitral regurgitation. So in theory, if you could reduce the afterload out here in the periphery, you might generate more forward flow and less backward flow. In severe acute regurgitation, like what occurs in endocarditis, this sometimes helps until you can get the patient to surgery. So patients who have acute aortic or mitral regurgitation can have a high sympathetic tone, and they can be hypertensive, and we will sometimes bring their blood pressure down to improve forward flow to help get them through the time until surgery can be performed. In chronic regurgitation of the aortic and mitral valve, clinical trials have had mixed and poor results. In general, afterload reduction has not been shown to be helpful, and these are surgical diseases, but sometimes on board exams, they ask you for the best medical option, and what they want you to recognize is that if you can lower the afterload, you can improve the forward flow and reduce the backward flow. Let's talk about tricuspid regurgitation. You should be aware that a small amount of TR is normal. This is called physiologic tricuspid regurgitation, and most of us have some degree of TR. Tricuspid regurgitation leads to a holosystolic murmur at the left sternal border, and there are a number of pathologic causes. So anything that enlarges the right ventricle can cause functional TR, just like enlargement of the left ventricle causes functional mitral regurgitation. Endocarditis is a classic cause of tricuspid regurgitation, especially among IV drug users. They tend to use dirty needles, and bacteria may be introduced directly into the venous system, and then the first valve it meets is a tricuspid valve, and that's where endocarditis develops. Carcinoid syndrome can lead to tricuspid regurgitation. And then finally, Ebstein's anomaly is a congenital heart defect of the tricuspid valve that I talk about in the congenital heart disease videos, and patients with this anomaly classically have significant tricuspid regurgitation. The last valve lesion for this video is pulmonic regurgitation. This is an uncommon valve lesion, and if you ever do encounter it clinically, it's almost always going to be someone who had tetralogy of Fallot that was surgically repaired in childhood. In the video on cyanotic heart disease, I talk about tetralogy of Fallot, and one of the components of this disorder is obstruction of the right ventricular outflow tract. When that obstruction is repaired surgically, that almost always damages the pulmonic valve, and years later, patients with repaired tetralogy of Fallot often develop pulmonic regurgitation. It's one of the major causes of morbidity in people who survive this via surgery in childhood. Later in life, they often need surgery on their pulmonic valve. Pulmonic regurgitation can also occur from endocarditis, although it's rare for the pulmonic valve to be involved in endocarditis, and it's also rare for the pulmonic valve to be involved in rheumatic heart disease, but that can occur and lead to pulmonic regurgitation. And that concludes our video on valvular heart disease.